Hello, good morning. My name is Didier Pité. I'm professor of medicine and hospital epidemiology at the University of Geneva Hospitals and also the director of patient safety at WHO Geneva headquarters in Switzerland. And here we are to discuss about the burden and the action to be taken in the control and decision making around intestinal infections that are very predominant, as you know, in the UK and in the rest of the world. Together with me today, actually a panel of a total of 5, the 5th person being in Canada. So I will let everybody introduce himself.
Good morning. My name is James Anson. I'm the medical director of Liverpool Clinical Laboratories. I'm a consultant microbiologist by training, and I work at the Royal Liverpool Hospital. And we have extensive experience of looking at multiplex PCR in the diagnosis of intestinal disease.
I'm Dr. Bharat Patel. I'm a consultant microbiologist in London. I work for Public Health England, and I'm based at Bart's Health Trust.
Richard Catlin. I'm Assistant Director of Infection Prevention and Control at Royal Bolton Foundation Trust.
Thank you. And in Canada, we have?
Hi, I'm Dr. Bridge Cook. I'm the Senior Vice President of Research and Development for Luminex Corporation, and my responsibility is the development of multiplex PCR tests.
Thank you very much. We'll start our debate by discussing the burden of disease. So, in other words, the first question we want to ask to ourselves is, within this context of intestinal diseases, what is the burden of disease in the community, and would this burden of disease in the community affect the healthcare system?
Okay, thank you. I think we've got some real data from a number of studies over the last 10 years. IID-1, which was Intestinal Infectious Diseases 1, and IID-2, which published in 2011. And they collected a lot of data around the burden of disease in terms of intestinal disease in the community. And I think it's fairly obvious that the disease burden is greater than obviously is reported by national surveillance. And it's something of the nature of about 150 times greater. So again, taking a global view of it, there's obviously 2 billion cases of diarrhea in the world and about 1.8 million deaths. But even coming closer to home, in the UK, we know that there's about 70 million cases of gastrointestinal infectious diseases per year in the UK, which is about 20% of the population. And about 1 million of those actually do present to the GP. Now, most of those, as we know, are 2/3 of them are viruses associated with Norovirus, but increasingly things like sapovirus, which is a diagnosis that we're obviously just getting hold of now. But I think in terms of the burden of disease, we know that those 17 million cases will actually lead to about 11 million days of work days lost and school days lost, and that has a huge socio-economic impact. That 11 million days of work lost actually equates to about £1.5 billion worth of lost into the exchequer. And when we're talking about the fiscal problems that we have at the moment within the UK, we know there's going to be a £2 billion shortfall in the NHS. So although that's not transferable money, there is a real burden, and I don't think that should be underestimated in terms of intestinal disease within the community.
Thank you. I think it's very clear that this is a disease that affects the community. And speaking of the number of days of lost at work, that really is something that needs to be here. So, any compliment?
I think the burden is also on the individual. The individual person that suffers from the gastrointestinal disease, infectious gastrointestinal disease. But occasionally there are outbreaks, and those outbreaks may cause disruption to the services or the restaurants, etc., that are associated with this. And clearly there is a burden for investigation of those outbreaks, and they do take up time to find one that through the diagnostics the pathogen. Secondly, how far it's spread, the vehicles of how that spread, and the control measures that have to be put in to control the outbreak and limit that particular spread. So there is a cost associated, additional cost, if an infection then leads on to an outbreak.
Mm-hmm. Now, speaking about outbreak, I'm turning to infection control. Is it frequent in your institution, for example, or is it frequent in the UK that you have to control outbreaks? And if yes, what would be the key pathogen responsible for outbreaks?
I think, as Jim has mentioned, it's largely viral pathogens, but with very little consistency from acute provider to acute provider about how to deliver diagnostic services for viral agents. Depends on how well and effectively you can manage that. So Jim's already talked about lost working days. We also have a huge loss of occupied bed days because we restrict admissions, we restrict discharges based on patterns of infection or perceived infection, and we can quite frequently be waiting 2 or 3 days to get samples and get samples tested with a sensitive test. That actually mean we can allow safe usage of beds. So we quite frequently have bed days closed. And then when we look at the closed communities out in the community away from the hospital setting, there's often a very low threshold for patients being admitted into hospital settings through A&E simply with diarrhea and vomiting, because samples aren't being tested in the community. And again, that frequently leads to inappropriate admissions, which is a poor patient experience. When sampling and supportive services like rehydration services could be delivered in care homes and residential homes without the need for patients to come and sit in an accident and emergency department for 8 or 10 hours, then go into a ward, and then they suffer secondary harm such as falls or lower respiratory tract infections because they're in an acute care setting.
Interesting. So you are talking about an outbreak in the community that comes to the hospital. We have experience, as you know, we being one of the largest hospitals in Europe, with this type of situation. We are affected by norovirus every season, but every season would be different. As we know, there are seasons where norovirus is important. The attack rate was, in the first years, so I'm talking 20 years ago, up to 40% sometimes. Nowadays, it's around 10%. We can totally control it with good infection control. So for us, it's not anymore a very important issue. And of course, you didn't mention Clostridium difficile.
I didn't.
Why so? Why so? Is it a problem in the UK?
It was a significant problem with the epidemic strain that we had, and the UK has gone through 3 epidemic strains: ribotype 001, ribotype 106, and then the most recent one, which is ribotype 027. The reported numbers were quite high, in the order of 55,000 mandatory reported cases. In recent years, there has been a significant reduction in that disease. One, because of good stewardship of antimicrobials, so good isolation, good awareness of the hospital to deal with this preventable problem, mostly preventable problem. And the number of cases are now around 17,000 reported cases.
If I remember correctly, the major impact on the C. diff outbreak in the UK has been the hand hygiene campaign.
Hand hygiene,
And
isolation.
of course, then better antimicrobial stewardship.
It was a care bundle. It was a multimodal approach, and it was 5 things, which was the hand hygiene, the isolation, the cleanliness of the hospital, personal protective equipment, and the antimicrobial stewardship. It was, but no one thing is the answer to controlling C. diff.
And the most important thing, which is identification. And I think where trust...
Was it really?
Was
it really making a difference?
Yeah, I remember working in a large hospital in Manchester, and the key focus as an external drive was the MRSA bacteremia targets. And our focus came from a risk-based assessment on patients' risk of transmission of infections to every patient with MRSA needs to be isolated because of the MRSA targets. And that was very much the feeling because of the top-down approach from the way that targets were perceived by hospital management rather than the way they were intended necessarily from the department. So what we were doing was transferring our risk. So we were isolating patients who could have been safely managed, in a shared room, into isolation in almost every account. And then the consequence of that was we saw more C. diff cases. So sometimes external drivers can apply pressures and have unintended consequences. But having them worked in a hospital that's had an outbreak with one of these epidemic strains, because we have focused very much on the identification of risk based on symptoms, what we've done is not just reduced the burden of C. diff infection, but also reduced the burden of viral pathogens, because from the front door, everybody's so keen to looking for infections and also asking about recent history of symptoms such as diarrhea. That we're actually isolating people from the moment they're in A&E rather than them getting to an assessment area and then someone noting that they've got diarrhea. So if you apply a more generic approach to diarrhea illness rather than always the specifics about one disease, you get multiple rewards.
Yeah.
And I think this is, sorry, I was going to say, I think this is where syndromic management or syndromic diagnosis comes in. So we're not just looking for C. diff, we're not just looking for a certain organism that's causing the problem. We're looking at a panel, and that syndromic management allows you to be able to have a more accurate diagnosis, and therefore utilising beds in a more accurate and cost-effective way. And I think that has been of benefit.
I think that has been the major. I remember when I got, sort of mandated to help and give advice to the UK. That was probably the major thing that we said. I mean, having a syndromic approach, making sure that overall infection control strategy would be better organized and in place. We remember that some hospital CEOs lost their position because of the bad management of the situation. So I think that, yes, I think that you did very well by handling this way, and not, it was not targeted according to the disease, but really targeted at implementing better overall infection control, including, of course, antimicrobial stewardship. That probably does not act immediately. I mean, we need several years.
And as you say, it is a care bundle, and we don't know which part of that care bundle has actually had the major impact. And it was never set up as an academic exercise to find out. It was just what we knew would have an impact, and it has.
Yeah.
I think the significant issues around that were mortality, because mortality was between 20 or 30%, at least in the more severe strains and in the more severe conditions. And we still have some mortality, but it is much less, and the epidemic strains and the severe strains have gone away, but they have been replaced by more community strains. And now the distinction between the hospital strains and the community strains is not so much. Mm-hmm. And I think the bigger picture here is, how do we actually manage diarrhea as a whole, both in the community, in the care home setting, and in the acute hospital setting. And part of the strategy, which involves primary care as well, is how can we reduce admission avoidance. Is, can these patients be better managed with rehydration? You can only do that if you work out the symptoms and make sure that there isn't a very highly infectious intestinal disease, etc. Make sure that you're aware that patients who have bloody diarrhea may need to be investigated a little bit further with the connotations of the toxigenic E. coli that we have. And again, that awareness of the range of pathogens that may cause the diarrheal illness. So it's managing the diarrheal illness, the diagnostics, and hospital admission, because the bed costs are quite significant, and even a 24, 48-hour bed cost, that bed could be used for some other clinical purpose. And so it's taking the whole range of diarrheal illness, including the diagnosis, and not just the norovirus, the C. diff, but the other organisms that do cause a problem. And there are certain groups that, say, perhaps salmonella would be an issue.
And
when
Shigella, but
Shigella
those
as well.
diseases are pretty rare. You are mentioning, diarrhea with blood, which is probably less than 5% of all diarrhea, or even 1% of all diarrheal diseases. So, what would be your strategy to actually discriminate between the patient with the SERV testing and the patient where you could only treat the symptoms and leave them home? Is there an algorithm for this decision?
There's no algorithm as such, but clearly those people who have to manage these cases in the hospital will make an assessment. One is the sort of clinical presentation. Two is the assessment after examination of whether this is a critical situation with hypovolemia, toxemia, etc. And the last basis would depend on the diagnostic test. And you can't make that happen within a few hours at the moment, but clearly that would be the sort of diagnostic pathway, a clinical pathway to follow, a care pathway for the patient to make sure that you are not discharging a patient that is hypovolemic, is pyrexial, and making sure that those needs are catered for, but that the patient who can be adequately rehydrated at home, is not toxic, and doesn't need antimicrobial therapy, then those patients can be managed quite adequately in a home environment where somebody's actually taking care of them. And that's the most important thing. You wouldn't leave an elderly patient on their own if they had a day or two of
I think the issue really is that there are some poorly validated analytical tools in terms of clinical diagnosis of diarrhea, but they are poorly reproducible. And when a clinician gets involved with a patient with diarrhea, exactly what Barrett was saying, they're really asking the clinical questions to the laboratory. What is this cause of the diarrhea? They're not asking, is this salmonella? They're not asking, is this Shigella? They're not asking, is this norovirus? And part of the problem is certainly in the UK, and I don't know what happens in Switzerland, but certainly in the UK, we have a very fractured and inconsistent way of testing and selective testing based upon clinical details, age, community setting, etc. And I think sometimes the implementation of a multiplex PCR, which gives you a comprehensive panel in a turnaround time which can be up to about 6 hours, can start to manage some of those issues directly for the patient, also for the organisation, and I think more importantly, or as importantly, in terms of informing public health policy. So most laboratories in the UK, some will look for S-Tech, some won't look for S-Tech, some will look for various other organisms, some will look for viruses, for everything. And it's inconsistent. So even if you collect all that laboratory data, it's going to be completely skewed by the fact that you've got inconsistent testing. But by putting a comprehensive panel together, multiplex PCR, and doing it in a time which actually has an effect in terms of being able to manage patients, I think it does, as Rick was saying, allow you to manage the beds in a more effective way. It allows you to be able to make decisions about rehydration at home. And it also eventually has an impact in terms of public health policy because you have better ascertainment of actually what's causing the diarrhea.
And let's not forget as well, the demographic of the hospital community is changing. As we see fewer and fewer acute beds, the ones who are left in the acute beds tend to be the older, frailer patients. And they're the patients that any clinician would be less reluctant to not test. So I think when Bharat's talking about an assessment for hypovolemia, that those risks are potentially a lot of the hospital admissions nowadays, with the patients not just over 65 now, but over 85. And in the local Northwest community, we've seen a significant increase in the number of patients, or a significant increase in the proportion of patients admitted to hospital who are over the age of 85. And a lot of those patients are being managed in their own homes safely, but things like diarrheal illness are things that have a significant and immediate impact on their ability to care for themselves safely.
I think the other aspect of this is that traditionally, laboratories here would do a standard. If it was a diarrheal sample, there would be a standard battery of tests, and that would be Salmonella, Shigella, Campylobacter, and E. coli 157. That would be
And
the four
CDs
bacterial.
if the patient is in the hospital for
that
more
would
than
that would have
several
to
days?
be that would have to be requested.
Oh.
If it's a primary care specimen, not all laboratories will automatically test for Clostridium difficile.
Even for a
Not
patient in the hospital for 3 or 5 days?
that would be requested to say a C. diff test is required.
Okay.
And that clinical information would need to be on the form because that information is not always entirely available. So the optional tests that come in are C. diff, parasites from a community side. That would, the primary care practitioner would have to request those tests, and also norovirus because it's a specialist test. But as we've heard from Jim, norovirus is not the only virus, and obviously we've had the rotavirus vaccine recently, but sapovirus as well are not the panel. They would have to be extra tests requested, or somebody would have to have thought of it to say, not viral gastroenteritis symptoms, norovirus negative, we will need some other tests. So that process needs to go through. And as I said, traditionally, it's just the 4 bacteria that people actually look for.
Yeah.
So, and that would be the majority of the hospitals, majority of the microbiology diagnostic laboratories.
I was asking the question because we published a paper 15 years ago from the laboratory demonstrating that when patients are hospitalized, if you get stool samples after day 3, except if this is an outbreak linked to rotavirus or norovirus, at that point we do only C. diff search because in 99 point something it was C. diff.
Some hospitals don't. Some hospitals don't test. If a patient's been in for a few days, they will not test for salmonella. Yeah, they will cut some of the tests out. So it's slightly inconsistent of how that goes, and perhaps there is an opportunity to have a
Further
good diagnostic
refine the strategy.
algorithm.
Yeah.
I think
Jeremy, you had a
it's also
comment?
very important to remember, at least in experiences that we've had with diagnostic labs, that generally greater than 60% of the patient samples that they test for from diarrheal patients actually cannot have any infectious disease agent found. And so that's a really important part of the overall picture as well. And I think that ruling in, one of the advantages of having a syndromic approach is that if you can rule in an infectious agent cause that can be treated in the community palliatively at home, then you take healthcare burden, cost burden off of the healthcare system. But then at the same time, you identify those 60% or so of patients who actually have other causes of diarrheal disease other than an infectious disease, and you get down different care paths for them that are more appropriate. And I think that's a very important aspect of having a syndromic approach to these patients.
And I think also it's important that you're saying obviously 60% don't have a pathogen, and it's really whether they do have infections that we're just not picking up. And I think one of the things that we are now involved with the Wellcome Trust grant is looking at pathogen discovery in outbreak situations in the community. So we are just about to embark on a fairly large project looking at pathogen discovery in those patients who we think have an outbreak associated with infectious diarrhea epidemiologically, but we don't pick up a pathogen by multiplex PCR. And in those, we have funding for about 50 microbiomes and about 50 viromes for pathogen discovery, which is, to be fair, what they did in Germany with the E. coli 104 outbreak. Is they used ion torrent and actually got to a point where they understood exactly what was going on. And so that obviously is important in terms of the basic research. So we actually continue to understand the epidemiology and new pathogens, and that then needs to be fitted back into the syndromic approach so we pick them up later on down the line.
Yeah, absolutely agree.
I think it's important to remind it, and we will discover a lot of new things with the microbiome, whether it's on viruses, bacteria, and so on. It's a new world that we are discovering. I like the idea of a strategy, and I like the idea of a clinical strategy. And of course, if a test will not change the attitude of physicians to take care of the patient or to install infection control, in this case, there will no need for a test. So I think that in the strategy, it should be discussed.
It needs to be a very consistent approach.
Yes.
And if we are to go down that road, then it needs to be consistent both for the community patient as well as the hospital patient, and we need some consistency. And part of this is that as you actually increase the testing and get the value, and from what our colleague was saying, what is the actual positivity rate? Because if we take blood cultures,
Yes.
positivity rate 5 to 10%,
Yes.
your 90% of your blood cultures are not yielding anything.
Yeah.
Yeah, patients being
But
had
you are considering a patient which is in a serious disease
Yes.
state because you are drawing blood culture, right? Whereas with diarrheal disease, the large majority will be over after more than 24 to 48 hours. Usually, as a physician, when you see somebody saying, "Oh, I have a gut flu" or something like that, you say, "Well, wait for 24 hours, and you will do fine." Of course, if the patients are older, the patients are somewhat dehydrated, if there is blood, we are going into a clinical pathway that makes sense. Then we need to be much better and more appropriate in diagnostic.
Yeah, and I think also the issue for syndromic PCR testing is that generally it is obviously far more sensitive, and consequently there is a debate to be had about the significance of PCR results, and I think that's a debate which still needs to be prosecuted. Yes. And I think the question around, which is in our experience and in the literature, in terms of co-pathogens and what that means, and I certainly am not an apologist for molecular methods. I just think we need to take those molecular methods and then be able to understand the clinical utility of them. So we have the same conversation about pneumocystis PCR. Yes. Because it's so sensitive, etc. What does it actually mean? And I think the same debate is going to be had around gastrointestinal or central nervous system or respiratory disease.
Respiratory disease.
It's going to be exactly the same
viral
conversation.
Respiratory disease. You discover 5, 6, 7 viruses, you don't know what to do with it, right?
Precisely.
Yeah.
I think that's important because we know that norovirus carriage without symptoms is there. We know other organisms are carried.
C. diff carriage.
Absolutely, without any disease. So finding it doesn't mean anything. It's finding it with the symptomatology that is going to be crucial for the diagnosis and relevant to the patient.
I'm looking at the question we had to sort of debate together. What are the challenges for laboratory testing, patient management, and potential antimicrobial resistance? We did not cover extensively antimicrobial resistance. Would you like to discuss
it? Well, let me go back. Let me go back to the laboratory first of all. I think one of the problems, as we alluded to before, in terms of diagnostics within the UK at the moment, is that it is very fractured. So it can be 3 laboratories. It may be under the same roof, but some of the feces will go to bacteriology and have the tests that you were talking about before. Some may go to virology, some may go to parasitology. And it's hugely labour-intensive and inconsistent. And I think one of the tantalising benefits of a syndromic multiplex approach is that it's all brought together under one roof with one test. And certainly in our hands, we've shown that by implementing it, we can actually make savings in terms of the labour costs associated with biomedical scientists who actually need to do those tests. And therefore, from a laboratory point of view, even before you go any further in terms of the healthcare benefits of it and antimicrobial resistance, from a laboratory point of view, it is actually cost effective to implement that because you can release biomedical scientists, which is real money to be saved, even though the upfront costs of the multiplex PCR might be more expensive. By the time you've you've multiplied the bacteriology laboratory by the virology laboratory by a parasitology laboratory with different methodologies.
Yes. And
different people. It is actually cost effective to have it. And I think one of the issues for us is how you scale multiplex PCR up. So if you're in a large laboratory, and of course with the Carter reforms we're all becoming larger and larger laboratories, how you scale that up in terms of ensuring that the PCR setup is automated, the extraction is automated, you don't get those transcription errors. But I think that's all manageable, and then it is literally just a way of running the laboratories. Most laboratories now are running 24 hours a day, and you can start to get those results back in real time, which is having a huge impact upon patient care.
Okay, so that's a very important message from the lab. I think that's very key. And the good thing is that then you can use these scientists, if you keep them, to do other things and new development and research, right?
Correct.
Okay, good. I think that's a good point. Next, what about the potential? Speaking of tackling antimicrobial resistance, I think that probably for infection control that would be very true. And probably in the community there is also some debate. Would you like to start?
I think we're very clear, and the UK has had a good track record of restrictive reporting of susceptibility data. So it would be very difficult for anybody to recommend antimicrobials for an ordinary salmonella infection. It would be very difficult for a microbiologist or an ID physician to recommend antimicrobials for a Shigella sonni infection. So our prescribing habits are quite limited on antimicrobial usage in that area. Where it becomes a little tricky is with Campylobacter. Because of the colicky nature of the pain, because of the symptomatology, and for the other Shigella infections, where one tries to limit the period of symptoms by using antimicrobials, then resistance would come through. Now, the issues around certain organisms which carry plasmids, and we have now seen the multi-resistant plasmids in E. coli being able to be transferred into Shigella and into some E. coli, and there's no reason why those resistances couldn't go into an E. coli 157 or a toxigenic E. coli, that those would be worrying developments, leaving aside the resistance patterns that we already know of in Campylobacter. And that sensitivity testing is done on Campylobacter, and that is released for the general practitioner. We would only treat invasive disease with antimicrobials, and I think that's the sort of general line that people would follow in the UK. Yeah. So although of a potential concern, it's not developed yet, but we view the carbapenem resistance, the mobile genetic elements of the carbapenem resistance, with a little fear.
Yeah. Speaking of infection controls?
I would echo what Bharat's saying there, and I think the organisations or health economies that have made significant improvements in those regards. Bharat and I have been involved with the Berkshire Health Economy, who've made huge improvements in their CDIF by working as a collaborative health economy. And I think it's pulling everybody together to see the multiple benefits, in terms of sensible antimicrobial stewardship in both the acute and the non-acute sector, and realising that one has an impact on the other, either directly or indirectly. And where you see trusts that have made the most significant improvements, it's largely an unchosen route, but where you've got infection control or laboratory services that have developed a common function because of changes to the healthcare provision. And I think that's probably the model for the future, is to pull economies more together as one. I know we've got a question later on about how do we avoid silo mentality, but that is still very much the culture in a lot of healthcare economies.
I think it's going to change. I mean, can't speak for the UK government, but I think that the next 30 years has seen a number of challenges in UK health, mainly because of the shortfall in funding, the ageing population who have to be happy and socially mobile and engaged, the new genomics which are coming along, etc. And I think there is a move now with the government to look at a thing called PIMS, which is places in the middle. And it's about integrating the secondary healthcare with primary healthcare. And I know that's happened in parts of London with great success. And I think that does help have a much more broad, integrated, vertical approach to healthcare across the health economy, rather than looking at the four walls of an organisation and saying, that's mine and this is yours. And I don't think that's been very helpful. And I think that silo mentality hasn't helped some of the discussions that need to take place for around infection control, because they don't stop at the doors. They happen across the whole health economy. And I think one of the pushes for the UK government in the next 30 years will be to have high-end diagnostics in the community. How that will play out, I don't know at the moment. I don't think anyone knows. But you could see the time when actually, some of these diagnostics are actually delivered in GP practices or in areas outside the institution by point-of-care diagnostics, which we can have, which don't need biomedical scientists. They need control, and that goes back to information and how we're going to have that. But I can see that actually happening, and therefore we're moving pathology, I think, away from where we have it at the moment, which is secondary care and tertiary care, back out into the community where actually the burden of disease is. And I think that will probably happen over the next 20 to 30 years. How it will happen and in what format, in what configuration, I still think there's a debate which is, being prosecuted probably 5 miles down the road.
And I think as we look at this, it's about remembering, clearly we've got an important role for the individual, but it's also about looking at the healthcare needs of the cohort of patients as well, whether that be a ward of patients, a hospital of patients, or a ward of patients in the wider sense of that. And I don't think we always do the best in the interest of everybody, because we concentrate very much on the interest of the individual, and I think we're starting to move in that direction.
I think that's important. The interest of the individual is also important, and we talked about earlier on, Didier, you mentioned Clostridium difficile, but there are patients who are on NG feed.
Yeah.
They get diarrhea. It would be good to know there's no C. diff there. Carry on. There's nothing to treat. And so even a negative result, a properly evaluated specificity sensitivity test, which gives a negative result, and you have confidence and assurance that yes, there's nothing untoward happening with that patient, then the NG feed could continue. We have antibiotic-related diarrhea, not C. diff diarrhea, but antibiotic-related diarrhea. And again, if you could make that sort of diagnosis, then that would be really helpful to the patient.
We did such a study in our 400-bed geriatric hospital, which means the 400-bed part of our hospital, which is really for very old patients. And actually, it was very clear. It was very clear that the main cause of diarrhea is not infectious diarrhea in conditions where it's under control. Which is easier because you got the patient in the hospital for a while, you know them, and then it's more how and when did they receive their type of nutrition and so on, and I think this could be key. But I agree. I mean, our issue, and that would be the last issue for the discussion today, is really this silo issue that. Preventive medicine, primary care medicine should go up and up and up, so that only very sick patients go to the hospital or to the healthcare setting, so that patients could stay in long-term care facility whenever possible, feasible, so that we don't have this exchange of patients moving from one place to another. So yes, in this case, we can see a potential advantage. But for these, we'll probably need more studies, right?
We will. And it's happened. It happened already, not certainly in gastrointestinal disease, but, for instance, BNP, which is a biochemistry test. We know that the investment in that in terms of pathology has actually released savings downstream in terms of cardiac failure and echocardiograms. And I think the same can be said in terms of molecular diagnostics, putting them in, which have a impact in terms of the acquisition costs, but actually they save money further down the line, either by real terms in terms of utilising less beds. And we're going to need to utilise less beds because our secondary care and tertiary care is shrinking, the state's shrinking, and therefore actually we need to be doing more into the community. So I think we really do need to try to understand how we broach that secondary primary care interface, and that silo mentality of here's my budget, here's your budget, and there the twain shall meet, I think has to be broken down by horizontal service line reporting, so we actually do truly understand it. And I think part of the success in terms of some of the trusts in London has been about the integration of community health trusts with secondary care trusts, and then you can actually start to budget and understand how to utilise the budgets in a far more flexible and constructive way.
I think
I think
other
there's-
aspect.
I think there's a big opportunity for funding for studies that can actually ascertain whether or not savings are able to be achieved in the healthcare system as a whole, using new diagnostic methodologies, for instance, or new care paths. At the end of the day, the silo problem, I think, can only be broken down by having holistic studies that actually collect data on what the economic impact is of new approaches and evaluate that compared to the current way in which care is given. And so that, I think, is the big opportunity, is to fund those studies so that actually it can be proven whether or not savings can be reaped across the healthcare system as a whole, rather than in any individual silo.
Yeah. So
Coherent care paths.
yeah, I think you're right, Jeremy, and I think part of the problem is the architecture within the NHS at the moment in terms of the way that pathology and other services are commissioned, which is different than obviously in North America and lots of Europe where you have reimbursement.
Absolutely.
And it's easier in some ways to understand how that then works. But with us being commissioned directly by CCGs, it makes it quite difficult because it is just often a block of money which comes in and we're expected to do everything. And of course you can't do everything, and it makes it quite difficult, as you're well aware, to actually get those studies done.
I think the other aspect is to make sure that as the shift occurs from a low bed hospital environment, we don't move any of the problems to the longer term care facilities. Absolutely. Because we already are seeing the literature full of information and data on long-term care facilities and the problems that some of them have started to have.
Yeah.
And we've got a very real risk in the immediate future with the acute toolkit for carbapenemase. I know it's not strictly an intestinal disease, but the spread will largely be by disease, symptoms of intestinal disease, diarrhea for non-infectious reasons, and people with carbapenemase producing organism carriage in the gut, is that we could replicate the issues we had in the 80s with MRSA, where we had a huge endemic population of MRSA patients in care homes, with no real clear strategy of how to manage those coming into acute care and leaving acute care. And we've got an opportunity to have learned from that episode. But again, this is about that syndromic approach, isn't it? About making sure from an IPC perspective that people know how to safely manage patients with diarrhea. Whether or not we give that diarrhea a label, whether we know there's a confirmed pathogen in there, whether we know there's confirmed carriage there, but where a wider suite of testing would come in benefit there is for not just finding a pathogen causing the symptoms, but the co-carriage.
Yeah. Does it mean that infection control will go? Your duty will extend to the community?
Well, that is happening now. So Bolton, where I've recently gone to work, have picked up the care homes from the local authority. It's been a bit of a rocky transition because not all of the monies that came from a provision of IPC to the care homes has come immediately. So the team's doing the best job it can with a small number of staff. But the plan will be for that to really go out and map what the needs of the community are. But I think that's a real boon for the future, because then we know there's a consistency in terms of the message that's being delivered from the acute sector and into the primary care sector, that we to some degree have some control of the message.
Yeah.
And what we can do is we can concentrate when we know there's an issue in the acute sector that might then transfer into the community sector, or vice versa, that we can communicate those messages in a very easy, transparent and unburdened way.
I think it is a direction of travel with the NHS at the moment in terms of integrating community infection control teams with acute infection control teams, and I think it feels intuitively the right thing to do.
This is what is happening in many countries, and it's good because the imbalance between some places, in particular long-term care and acute care, is really something that we pay in the mid or long term, sometime in the short term. So it's certainly very important. So I think it was fascinating. I will give you a few words if you want. If you have to conclude in one sentence, in the laboratory.
So I think in the laboratory we have a real opportunity with novel, innovative diagnostics to make a difference for the clinicians in terms of giving them comprehensive diagnostic panels in real time, which actually allows them to make decisions based upon good sensitivity and specificity data.
Thank you. Would Jeremy have something to add?
Yeah, I look forward to the continued discovery of new causes of diseases. We apply more powerful research technologies to discover additional pathogens and different genotypes and so on, and implementing those in new versions of tests that would provide even better comprehensive syndromic coverage for these difficult diseases. And I also look forward to greater availability of NHS-led healthcare economic studies to demonstrate the value of these new technologies to the healthcare system as a whole.
Thank you. Jim?
I think the most important thing is the improvement in the care pathway for all patients, and the diagnostics will help, and it will lead to better outcomes. So I think better outcomes and quality improvement is the way forward.
Yep.
I would just say my job is largely based on risk assessment, and what we're doing is assessing the risk on the information that's available. The more information we've got available, the better that risk assessment will be, with the bottom line being patient experience. The direct patient experience isn't just the experience of the symptoms from gastrointestinal disease, but also the effects of isolation. Most patients, at least in the UK, prefer not to be isolated when in hospital. It can be very detrimental to their mental health and to their social reintegration. So the value of a negative test is equally paramount as a positive test, because it means the patient gets a better experience.
Well, nobody likes to be isolated, not only in the UK.
Oh, I do.
So the conclusion would be that we learned a lot today. We learned that there will be an exciting future for intestinal infectious diseases. We learned that it will change the face in the laboratory. New clinical pathway, infection control will be more proactive. It's good. It's an exciting future. Thank you very much, every one of you, for this morning panel, and have a good day.